Friends, this patient has severe non-proliferative diabetic retinopathy with macular edema and this grade 2 plus cataract. So I have planned cataract surgery along with intravitreal injection of Bevacizumab. The surgery has been started. The main incision has been placed at a selected site. 2 side ports have been made on either side of the main incision, and now a cystotomy is being used to incise the anterior capsule and a flap is raised. This capsular tag is held with a ureter forceps. The patient is not cooperative and I am fixing the eyeball with a toothed forceps, holding it just near the limbus. Capsulorhexis has been completed. Now hydrodissection is done. At this time I have released the hold with toothed forceps. The nucleus is rotated after mild decompression. And now is the time to enter into the eye with the Phaco handpiece. In this case, Oatley's Cataracts 3 Phaco machine is being used. Here it is. And I usually do direct chop. Here it is. The nuclear mass is held with vacuum. The Phaco tip is embedded into the nucleus and the nucleus is chopped with this very small chopper designed by me. I feel afraid to use a long chopper, though I know that the thickness of the lens is about 4.7 millimeter. The nuclear fragments are being emulsified and engulfed. Phaco power used in this case is 60%. Flow rate is 45 ml per minute and vacuum is 450 millimeter of mercury. The last nuclear fragment has been emulsified and there is no epinucleus in this case. Little bit of cortical lens matter is there. A bit of viscoelastic substance is injected into the antechamber, and now a Simcoe cannula is being used to remove the cortex. In this case, I have used a caliper to measure the point of entry for intravitreal injection. When the patient is aphakic or pseudophakic, I inject about 3.25 millimeter away from the limbus. The cortical lens matter has been removed. Now this is SPMC being used to fill up the capsular bag and anterior chamber, and this is the lens. This is a hydrophobic acrylic intraocular lens. The leading haptic has gone into the capsular bag and the trailing haptic has also gone into the capsular bag. The haptics were in handshake posture. It was released and the lens is dialed and the haptics are placed at 3 o'clock, 9 o'clock positions. Now I do a thorough removal of viscoelastic substance. I take about 2 minutes time to remove this viscoelastic substance, and my patients are happy. I want to see a happy face of a patient in the post-op period next day. And if we don't remove this viscoelastic substance thoroughly, there can be a rise of intraocular pressure. Even there can be steamy corneal edema. So to avoid all those things, what I do is I remove the viscoelastic substance thoroughly, first with irrigate with Simcoe cannula, then I irrigate with the irrigating probe or bimanual IA as it is being done now. And thus most of the viscoelastic substance that was injected has come out. We can reduce the surgery time if we don't use this. Now this is the measurement, about 3.2 millimeter, 3.25 millimeter away from the limbus. 0.05 ml of Bevacizumab is being injected into the vitreous cavity. I raise the intraocular pressure by the irrigating probe being placed in the anterior chamber, and now Bevacizumab is injected. It was an oblique entry, just as we introduce the 23 gauge trocar for vitrectomy. The entry is oblique like that. Now the side ports are hydrated so that these stab incisions become waterproof. So it is a good idea to inject intravitreal Bevacizumab if there is macular edema because of diabetes. That's it. The antechamber is formed like this and the case gets over. Thank you very much for your kind attention.